So I'll go ahead with the next talk. Actually, it should have been followed by the basics principles of how to do a good measurements of keratometry and excellence, but the first speaker has not reached probably in time. So I'll go ahead with my talk. Project कर दीजिए please, नहीं आया है उस. Okay. So I'll be talking about optimization for your own results for every patient of your cataract whom you are going to operate upon. That's the way to go. That's what my take is, and that's what I'll propagate. We have an armamentarian of AIOS formulas with us. Still, we land up with refractive surprises. So why is it? So is there a problem with the formulas? Yes. Each formula has its own limitations. So no statements. There are statements, SRKT is good for long eyes, Hofer Q is good for short eyes, but are these the correct statements? Because still with these formulas in those appropriate eyes also we'll end up with refractive surprise. And this is one example which show you with same readings of your basic keratometry and excellence and using 4 different formulas which I have shown, you'll have so much of variation of the IL part calculation. So this is the reason we are landing up with refractive surprise despite our best efforts of doing the best measurements and the best IL power formula which we have incorporated and used. So what is happening? Because of these problems which are inherently there, I may be choosing incorrectly, and I may be landing up with a patient where I have done an excellent surgery, my cornea is pristinely clear next day, eye is quiet, but the patient is still unhappy. This is because he has landed up with a high refractive error. So what do I do? The need is the optimization. Because as Vinita said, not even the toric IOLs, every cataract surgery is now a refractive surgery. So what are the other sources of error? Besides the measurement errors like the corneal compression, the calibration errors, there are certain inherent errors which we are presuming, like the speed of light, the refractive indices, and certain erratic errors which I'll be listing. This is, remember, every patient's anterior and the posterior segment of the eye are not exactly proportional for every patient. So then we have the sources of error which are arising because of the IOL designs. The angulation, their overall size, the shape, the rigidity of the optic haptic junctions, their biological interaction with the capsular bag which may vary from eye to eye, and the effective lens position which obviously another speaker will be talking about. So we all know short eyes produce a shallower ELP and longer eyes will result in deeper ELPs. And then we have the surgical technique which varies from surgeon to surgeon. So your axis size, your lens gets centered, where is it being placed, whether you have done a very thorough viscoelastic removal or not, what is your suturing in case you are applying a suture, and the use of postoperative steroids which modulate your wound healing. So the IL formula, if we just take by the simplest of the form, we all know is lens constant and axial length and keratometry are the 3 factors which are the important factors. And these lens constants which are given by the manufacturers have multiple variables included in them. So the A constant which we all know which is mentioned on the IOL box, it is an empirical value which is being given provided by the manufacturers of the lens. And this has been based on certain theoretical considerations with limited clinical data and experience with similar lens designs in the past. This is how they have derived, the manufacturers have derived at it. And these constants, however, remember for every formula they are different. We have for holidays surgeon factor, for Hofers we have the PACDs, for Hagies we have A0, A1, A2, all these which are used as a starting point. But remember, for optimization of your own results, you need to have these basic ingredients which we all do when we are doing a cataract surgery, your preoperative keratometry, axial length, IL power in the model which you are choosing, and your postoperative refractive errors of your previous cases. So for your optimizing your own results or finding your own optimized A constant, you need to have previous experience of your previous cataract surgeries and their postoperative refractive errors. Remember, this can be done, optimization should be done for your own cells, so you should be not using cases for taken or operated by different people. One surgeon, one lens model, one biometry setup, one style of surgery, in the back placement of IOL, and a standardized refraction done by one person. So all these things should be there when you are doing optimization of your own results also. So an example is like we take this SRK formula. As I said, this is the basic formula. If we rearrange, this is how we derive at the A constant. Now let's calculate the A constant for a case of series, average these values, and use this new A constant for your future IL power calculations. For effective and a meaningful result, you can just take 25 of your cases with all those prerequisites I said: one surgeon, one biometry machine, one type of surgery, one type of IOL design in the back placement. So all these things, take your 25 cases with their post-operative refractive error, do the back calculations, and you'll be able to derive at your own optimized A constant. So back calculate for every case, as I said. But if you start doing these back calculations for these surgeon's factor or these A constants, it is very, very complex mathematics involved. There is also another method which is described, which is the Aristotelian methods, where the predicted error is given as measured value minus the predicted post-operative refractive error. And for this, you need to have at least a sample of 100 eyes. So all these require a lot of paper and pen optimization, and this can lead to a lot of time-consuming aspect, and besides this, lots of errors, human errors which can arise. So more sensible would be to use a biometry machine to do this optimization for you, or use a separate software. So using the biometry machine, you can use that, enter the post-operative refraction in your biometry machines, and the machine will calculate and update the relevant A constants for you. Or a simpler method than this is using a software on your computer, which can be done at any point, sitting anywhere, on your desktop, on your laptops, or even on your mobiles now, with the updated software in it. So easier to transport data in this, faster, and no memory-related overload issues which may be there with the biometry machines. So this is one lens constant optimizer which was designed by one of our person with whom we started this course, Saurabh Sani. And also we have Dr. Hill's spreadsheet, which is available online. So this is a format of the lens constant optimizer. How does it work to give this? So it gives you a suggested A constant, like this is conventional optimization of the optical and the ultrasonic biometries. Same way it gives you after the conventional optimization. And we have something called as, beyond this conventional optimization, we have something called as DIO, which is another software developed by the same person I'm talking about, Dr. Saurabh. And again, we have the Holiday IOL Consultant also, which are both available softwares, which are both paid. They are not available for free as compared to the lens constant optimizer, which is available for free. And what does this DIO, since it is developed by one of my colleagues, so I'm just talking about it. It maintains your database. It performs extensive data analysis, produce optimized IOL power, and a single IOL power is provided. You need not worry which formula is better or which formula is bad. So everything is automated. Just need to bring in the basic parameters. You need to feed the basic parameters and it will work for it. And so in the end, I'll just say, is optimization worth the effort? Yes, it is. Because with optimization, you're able to receive the same result in almost 90% of surgeries as opposed to without optimization in 70% of cases. And with DIO and using ultrasonic biometries, it is almost 96% of surgeries. And using optical biometries, it's almost 99% of cases that you will have within ±1 diopters. Thank you. So I would say, yes, optimization is worth it.